A unique subset of functional mitral regurgitation is ischemic mitral regurgitation. The mechanism we're looking at here is with progressive LV enlargement, you have annular dilation of the mitral valve, and you also have papillary muscle displacement. As that LV cavity enlarges, you have apical tethering, where the papillary muscles become taut, the chordae become tight, and you have restricted leaflet motion during systole. So when the valve would normally coapt well, those leaflets are more restricted and can't coapt well, and so you have mitral regurgitation through that space. It's pretty common to see this slightly posteriorly directed jet when you have that restricted posterior leaflet seen in this echo clip. We're going to focus specifically on this posteromedial papillary muscle and this inferior and inferolateral wall when we think about how CABG may actually improve MR without addressing the valve. Now, there's two schools of thought, and the first one is if you revascularize the PDA, which supplies that territory, most commonly the RCA in right dominant populations, whereas it could be the left circumflex in left dominant populations, you can improve left ventricular function and improve remodeling of that left ventricle, which would decrease papillary muscle tethering and increase leaflet coaptation, thereby improving the mitral regurgitation. However, if you attempt CABG and it doesn't improve, the risk here is moderate MR that is uncorrected and worsens has been shown to lead to poorer functional status, more hospitalizations, and reduced late survival. So it's important to get this right because if you have the chest open and you may address it, it's got to be done correctly. And just a reminder that that posteromedial papillary muscle is one we focus on because it typically is more vulnerable to ischemia or infarction-related changes because of its single blood supply as opposed to that anterolateral papillary muscle.